A very good evening. A very good evening to everyone. The topic of my presentation is medication adherence in patients with type 2 diabetes mellitus treated at a government tertiary hospital. So now it's I have been talking in this because it is one of the important issue that adherence to the medication, whether anti-diabetic or anti-hypertensive, and both these diseases are non-communicable, and one of the important diseases if we find many patients in each and every household and every known to us. So a lot of drugs has also been introduced in the armamentarium, and as a lot of insulin has also been introduced, but still we are not able to control the diabetes or a metabolic syndrome or something like that. Why? Because there is a lack of adherence. Non-adherence is just moving on at a very fast speed, and in this study I have been tried to find out some findings regarding the non-adherence and etc. So I must proceed. Introduction. Diabetes mellitus continues to be a public health problem worldwide, with the number of people presenting with diabetes estimated to be 783 million by 2045. Okay, so materials and methods. It's a cross-sectional study conducted in the OPD of Department of Internal Medicine, King George's Medical University, Lucknow. The study protocol was approved by the Institutional Ethics Committee of the institution, and informed consents were obtained from all the study participants who were patients attending the diabetic clinic of the institution during the study period and suffering from type 2 diabetes. The study participants were selected on the basis of the following: inclusion criteria: subjects having diabetes and diagnosed according to IDF guidelines, patients with type 2 diabetes and on oral hypoglycemic medications, the patients who were aged 20 years or above, the patients who were non-pregnant or non-pubertal at the time of the interview, those who have given informed consents to participate in the study. The exclusion criteria: subjects having any CNS disease or psychiatric disorder, subjects on insulin therapy, patients not willing to give consent, and patients who were included were all having T2DM and were over 20 years of age with ongoing treatment. Each participant was interviewed by using a pre-designed, pre-tested structural enrollment form, which included socio-demographic variables like age, sex, the educational and the marital status, the per capita monthly income, and specific questions on the duration of diabetes, the type of medications which were prescribed, the compliance to anti-diabetic drugs, the diet plan and the exercise schedule, and associated complications of diabetes. The level of medication adherence, which is one of the important part of this study, was assessed by using a structured, pre-tested and validated validated reporting scale, Hill-Bone compliance to blood pressure and the diabetes therapy scale, Mukherjee medication adherence scale at a scale the adherence. A 4-point Likert scale was appointed for each question. None of the time it was 4. Sometimes 1 to 4 times per month, so it is 3. Most of the time, more than 5 times per month, or more than 2 times per week is equal to 2. All the time is 1. The total scores were added to each patient. The scores may range from 7 to 28. 7 will be minimum and 28 was maximum. Based on the scoring system used in the Mukherjee medication adherence scale, a total of 27 and above was considered adherent. The questions highlights the forgetfulness of medication, measures medication use, stops to take medication when feel worse, forget to take medication when travel or go out of home, measures medication use in yesterday, stops to take medication when feel better, feel dissatisfaction due to daily commitment to take hypoglycemic medication, facing difficulties to remember to take all the medication. The maximum score 27 and 28 represents high adherence, 23 to 26 represent medium adherence, and below 22 represents low adherence. The statistical analysis: chi-square test was used to test the correlation between adherence and non-adherence, and also to compare the level of adherence with difference in age, education level, marital status, disease duration, drug regime, monthly income, and smoking. Regression analysis was used to find the possible factors for non-adherence. Binary logistic regression analysis was conducted to identify factors associated with non-adherence while adjusting for covariates. Now results. The table 1 is adherence level. 159 patients, about 54.8% patients showed low adherence, 34.5 showed medium adherence, and 10.7 showed high adherence out of the 290 patients, as 350 patients were included in the study, but the 60 patients were lost to follow-up, so 290 patients were the final value. Comparison of age based on adherence. Low adherence, the patients who showed low adherence, the minimum age of mean age was 43, and lower bound was 40 and upper bound was 45. Medium adherent who showed the 49.9, 46.9 was lower bound and 52.8 was upper bound. High adherent for 53.6, lower bound 47.8 and 59.4 upper bound. So the p-value was not significant. Comparison of adherence level based on education level. Again, the p-value was not so significant. Comparison of drug regime with based on adherence level. In this also, the p-value was not so significant. There are three main factors which may contribute to non-adherence to medication: non-adherence to regular follow-up in diabetes clinic, and non-adherence to healthy diet, and non-adherence to instruction to take medication. Conclusion: majority of patients have low adherence scores, have duration of diabetes from 5 years or less, take more than 3 medications, and having monthly income of 5,000 to 10,000, and were non-smokers. There is no significant difference term of adherence between different disease duration, number of drug regime, and smokers and non-smoker. About half of the patients have comorbidities, and there is no significant difference between patients with or without comorbidities in terms of